Welcome to Chapter 15, Secondary Assessment, Emergency Care, 14th edition, uh, for the EMT. So we're going to talk about the secondary assessment generally, and then the medical patient, the trauma patient, and a detailed physical exam. So components of the secondary assessment, so there are three categories of patients. There's the medical patient, the trauma patient, and the unknown patient. Generally speaking, we're going to talk about the components of that secondary assessment. Generally speaking, include the physical exam, patient history, vital signs, which is something that you can see, and then a symptom that's something that the patient tells you. So a sign is a subjective. I'm sorry, sign is objective. A symptom is subjective. So, yeah. And then reassessment is a continual process. So the medical patient. So assessment varies depending on the patient's ability to communicate. So you can have a responsive medical patient or an unresponsive medical patient. In the responsive medical patient, you are going to obtain a patient history, perform a physical exam, obtain baseline vitals, and administer any kind of interventions and transport the patient. Okay. When we obtain a patient history, we're going to obtain it from the patient first. And then if the patient is unable to communicate, then we're going to talk to family or bystanders. Sometimes those patients will just defer to their family members because they know more. And then you're going to base your questions on the chief complaint or observation, asking those open-ended questions and more specific questions towards the problem itself. And then use that sample mnemonic. We're going to tailor the physical exam for specific chief complaints. Okay, so we can gain important information and treatment-bearing information by tailoring our history to that specific chief complaint. Okay. The physical exam is usually brief. We're going to examine areas of concern based on the chief complaint. We're going to obtain those baseline vitals, so blood pressure, heart rate, respiratory rate, pulse ox, skin color, temp, and condition, all of those things. And then we're going to administer any kind of interventions and transport the patient. Remember that if a decision for prompt transport of critical patients or those with specific complaints is part of the treatment plan. On a pediatric note, you're going to get on the same level as the child, put questions simply and in simple language, and gather information from caregivers. In our unresponsive medical patient, we're going to begin with the physical exam and baseline vital signs. Those baseline vital signs are going to guide your patient assessment and the physical findings as well. Gather history from relatives or bystanders, and do a rapid assessment of the entire body. When you do a rapid physical exam, it's similar to a head to toe exam for a trauma patient. You're going to assess head, neck, chest, abdomen, pelvis, extremities, and posterior. Basically, you want to put eyes and hands on the patient and see if you can find anything wrong physically or see anything. So you're going to check the neck for JVD, any kind of medical identification devices, breast sounds, abdomen. You're going to check for distension, firmness, or rigidity. In the pelvis, you're going to look for incontinence of urine or feces. Extremities, you're going to check for PMS, oxygen saturation, any kind of medical identification devices, and check for pupils. Then you're going to check your baseline vitals, the pulse, the respiration, skin, pupils, blood pressure. You're going to take note of any abnormalities and determine your patient's oxygen saturation. And then you're going to consider your request for ALS. So follow local protocols, consider if a paramedic would benefit your patient, Some areas may not have ALS options. You're just going to consider and maybe just consider the closest option for healthcare facilities. Obtain a patient history. So you're going to question bystanders. What is the patient's name? What happened? Did you see anything else? Did the patient complain of anything before this happened? Does the patient have any known illnesses or problems? And is the patient taking any kind of medication? And then we're going to look for injury or signs that suggest a spinal injury. And if needed, we're going to immobilize the patient. All right, so secondary assessment of the trauma patient. Injuries can range from slight to severe. To determine how serious an injury is, consider the location of the injury or injuries on the patient and the patient's mental status. Patient's airway status, vital signs, mechanism of injury, patient's age, or any kind of pre-existing conditions. So a trauma patient with minor injury or low priority, assessment is focused on the areas that the patient notes are painful or that mechanism of injury indicates. We're going to determine a chief complaint and conduct a history of the present illness to gain information on how that injury occurred. Okay. Chief complaint is what the patient tells you is the matter. Patient history, so nature of the force involved, direction and strength of the force, protective equipment used by the patient, actions taken to prevent or minimize injury, and areas of pain or in injuries resulting from the incident. Areas assessed depend on injuries and chief complaint. The mechanism of injury may point to potential injuries. There are 3 techniques: observation, palpation, and auscultation. You cannot properly assess your patient if you do not put hands on your patient. Okay. When you do a physical exam, your decision on which area of the patient's body to assess will depend partly on what you can see and what the patient tells you. And your mechanism of injury must also be considered. There are 3 techniques of physical exam that you have to master: that observation, palpation, and auscultation. We're going to look for observe, symmetry, color, shape, and movement. You're going to palpate for shape, temperature, texture, and sensation. And you're going to auscultate for decreased or absent breath sounds. So DCAP-BTLS is an acronym that can help you remember what you're looking for when you go to do a trauma exam, rapid or fast, or rapid or slow. So DCAP-BTLS stands for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. Okay, so these are the things that you're going to look for when you do your rapid trauma exam or a focus exam. You're going to obtain baseline vitals. So early vital signs provide a snapshot of stability, and vital signs provide a baseline for future assessment. Spinal motion restriction, or SMR, applying a C-collar. So we're going to apply a C-collar to any patient who requires spinal precautions. C-spine immobilization device should be rigid, and we're going to make sure that the collar fits right. Complete a primary assessment and care for life-threatening problems before applying for that C-collar. Use a mechanism of injury and patient condition to determine the need for cervical immobilization, and assess the patient's neck prior to placing a collar. And then always reassure your patient. We're going to size the collar appropriately. Most of the adult collars have adjustable that are adjustable, and so you can size them. Pediatric ones are one size per neck, so you may have to get like different sizes. We're going to remove any kind of jewelry and move hair out of the way, and then keep the patient's head in an inline anatomical position. All right. Trauma patient with serious injury or multi-system trauma or a high priority patient, continue that C-spine. Consider a request for ALS. Perform a rapid trauma assessment head to toe, and complete that head to toe assessment with DCAP BTLS. Consider any kind of hidden injuries, seatbelt injuries, airbag injuries, or steering wheel injuries. All of these injuries can create problems inside the chest and abdomen, create bleeding, contusions, anything like that. And they might not be bruising, but there's still those hidden injuries that we can't see. Continue your spinal precautions. Request for ALS. Your rapid trauma assessment requires only a few moments, and it should be performed at the scene. Care provided en route will be based on this assessment. So rapid assessment of the head. Again, we're going to look for DCAP BTLS on the head, the face, anything like that. And we're also going to look for blood and clear fluid, which is an indication that there may be internal head injury. Clear fluid is typically a cerebral spinal fluid. So if we have that clear fluid, like a halo sign, then bad thing. Battle signs. These are serious findings. Battle signs are when you have both eyes are black, and then assessment of the neck. So wounds, tenderness, deformities, jugular vein distension. Look for any kind of stoma or tracheostomy. Apply a C-collar. In the chest, we're going to look for any kind of paradoxical movement, where one side of the chest or one portion of the chest moves up and the other portion moves down. Look for that crepitation. Breath sounds. Rib cage and chest must be exposed. You have to expose your patient in order to put eyes on the patient. Okay, you can't see through clothing. Auscultation. We're going to listen for breath sounds and then palpate that chest. The abdomen, we're going to look for any kind of distension or pulsating masses. Gently press down on the quadrants. If you find a pulsating mass, you don't want to press down on that pulsating mass, because it typically means that there is a AAA or an abdominal aortic aneurysm, and you don't want to make it rupture. Look for, in the pelvis, you're going to look for bleeding and priapism. Priapism occurs in males, and it's basically an erection. It's just a random erection. There's probably no stimuli to cause the erection. It can happen with nervous system problems. Extremities, check for wounds, tenderness, deformities, that DCAP BTLS. Okay. And then you're going to look for circulation, sensation, and motor function. So this can be called CMS, PMS, whatever you want to call it. PMS is pulse, motor, and sensation. CMS is the same thing, circulation, sensation, or circulation, motor, and sensation. It can be called CSM, whatever you want to call it. I really don't care. But basically what we're doing in all four extremities, we're going to check to see if there's a pulse. We're going to check to see if they have movement. And then we're going to check for sensation. Can you feel me touching you? Can you feel this? Blah, blah, blah. Posterior body. So you're going to roll the patient on their side, then assess, slide in an extrication device if you need to, for movement of the patient, obtain baseline vitals, and past medical history. Some general principles. Tell the patient what you're going to do. Expose the injured area before examining it. Maintain eye contact. Apply spinal precautions. And stop or alter your assessment process to provide care. There is some argument, discussion over whether or not we need to stop and provide care or we continue our assessment. I read something recently about how we miss parts of the assessment because we stop and provide care, versus what we should be doing. We should have a team, right? Typically, we get fire, we have our partner. So, what can they be doing while you're doing your assessment? If one person is doing an assessment, the other person, that person can be like, hey, I found something needs to be treated, and then somebody can be assigned to treat that, and then that person who's doing the assessment can move on. So I would take that into practice rather than stopping and doing something first and providing care, because you could miss something in the assessment that shouldn't have been missed. Pediatric examinations. So on the head, we're not going to apply pressure to those fontanelles. Collisions can produce head injuries more easily to kids. In the nose and ears, we're going to look for blood and clear fluids. Any kind of mucus or blood clot obstructions can disrupt breathing. In the neck, they have proportionally larger heads that increase the chance of spinal cord injury. They can have a spinal cord injury without spinal bone fractures. In the airway, we're going to keep the head in a neutral position and keep the kid's head in a neutral plus or sniffing position. The pediatric chest, look for even breath sounds, check for symmetry, bruising, paradoxical movement, and retraction. In the abdomen, you're going to note that if it's rigid or tender, injury that impedes movement of the diaphragm can compromise breathing as well. Pelvis, you're going to check for pelvic stability. You're going to push down and in, which is kind of an antiquated deal because it really doesn't tell you anything anymore. It's just check the pelvis. If it feels unstable, then we may have a pelvic fracture or something like that. Extremities, cap refill and distal pulse, check for painful, swollen, and deformed injury sites. The detailed physical exam, so this is done after your rapid if you've done a rapid. And this can be completed en route to the hospital. It gathers additional information. It helps to determine treatment for the patient and will assist emergency department staff. It's performed most often on the trauma patient with significant injury. So you do your rapid on-scene rapid trauma exam, and then after you get them in the back of the truck and you've got a little bit more control, you've got some time to do things because we've taken care of all the life-threatening things. Now we can go focus on the non-life-threatening things, and we can kind of take our time to do a detailed physical exam. Trauma patients with significant injury. So for these patients, you will have assessed almost the entire body during the rapid trauma assessment. And now, in this detailed trauma assessment, you're going to give the body a more thorough look over. You're going to look at possible signs and symptoms of any kind of injury that you may have missed or may have changed since the rapid trauma assessment. So before beginning that detailed trauma exam, remember to perform this only after all critical interventions have been done. And if you are treating a severely injured patient and are too busy to complete the detailed exam, it's not a failure. You just had too much to do. Okay. Sometimes I don't even get past in a rapid trauma exam. I don't get a whole lot. I give the body a once over. And then move on. It's your responsibility to give the patient best patient care possible, which may mean skipping the exam in order to maintain ABCs. Expose the patient. Noise and motion may interfere with some procedures. sometimes it's hard to hear in the back of the truck when you're auscultating for lung sounds. Work a lot around the immobilization equipment. Components that are similar to the rapid trauma exam, just kind of a more detailed and focused. For the trauma patient who is not seriously injured, they generally don't need a detailed physical exam. You keep a high index of suspicion, and when in doubt, perform that detailed physical exam. Just be aware that of the patient's fears and need for